Okay, this is part 2 of the fractures. So another situation we need to look at is Salter-Harris classifications. Um, so we'll look at, these are more of your growth plate fractures. Typically very impactful because these are your adolescent growing children types who need good healing, good alignment for the bone to repair properly. So a Salter 1 classification is just separation of the through the growth plate. So it's across a growth plate here. So if you see a fracture through these growth plates here, and they are not as devastating as others. As long as you can get the growth plate realigned, you should have decent chance of resuming normal growth of the bone. A Salter 2 here is a fracture through the bone and then through into the growth plate here. So you see a fracture line that goes through part of the growth plate and part of the long bone. In this case, you see the growth plate here. You see a fracture through the intra-articular portion and separation of the growth plate as well. So this is a more serious fracture that needs to be aligned well and fairly quickly in order to resume healing. A Salter 3 is one that separates the growth plate into two portions and occurs through the end of the growth plate here and separates the long bone into two portions here. So you see a change in the alignment quite often in these pieces here. Salter 4 is through part of the bone and then through separating both of the end portions of the bone here. And then a Salter 5 here is just a separation of or more of a compression fracture of the growth plate here. So this is one where the growth plate has been compressed and impacted, which can impact the ability of this bone to fully grow. All right, so that kind of completes the Salter-Harris classification. Here you see the cardinal signs that we look for in OA. So joints, narrow joint spaces, subchondral bone sclerosis. So you see a little bit of light, white here for the sclerosis. You see decreased joint space. You see an osteophyte here where this bone is formed due to loading that sticks out away from the femur. You may see some debris occasionally. Subchondral cyst are sometimes present, and then malalignment. So you see a definite loading of the medial compartment versus a separation of the lateral compartment. Another approach we need to look at is for bone tumors. So I say signs and symptoms: pain, swelling, deformity, pathologic fractures, the weight loss, all the things that we look for in our red flags. You may see some lab changes there. So we really want to classify these tumors into malignant versus non-malignant. So our metastatic versus primary tumors as well, and also by tissue of origin. So is it a bony tumor? Is it a cartilage-based tumor? Is it a soft tissue-based tumor? Is there a vascular component to it? Those type things. So really, when we're talking about tumors here, we're talking about is it cancerous versus benign? Is it primary tumor, or is this a metastasis of the tumor? And is this related to the bone, cartilage, soft tissue? So as we look at these things, they can be lytic or blastic, calcified versus non-calcified. We're going to look at the border of the tumor. We're going to look at soft tissue involvement, which may suggest malignancy, and then periosteal reaction, which may suggest malignancy. So we'll be talking about those things here. So here you see different components. So osteosarcoma is usually found in this thing, the chondroblastoma. So this is more bony tumor. This is more cartilage tumor that we'll be looking at, or some bone cysts that you may see. So giant cell tumors are typically down in this area, encompassing both. Really don't care that you know the exact location. Just know that cartilage is going to be found more in the cartilaginous area. Bony can be found anywhere in the long bone. So looking at those things primarily. So here's a blastic lesion. So this is a tumor that's growing more over than it should. So it's expanding this tissue, but you see it's not uniform. There's more of a growth here than should be. So we'll be looking at that. That's more of what we'll call a blastic tumor. Whereas a lytic tumor eats away the bone, so it takes away the bone. So instead of having a nice bone here, you see that it's been kind of eaten away. It's disappearing here. It's very lucent here. So you see a lot of bone missing here. This is more of a lytic lesion of the bone here. Calcified lesion. Here you see a big calcification of the bone, and you see some soft tissue dotting here that indicates there's some calcium formation in the soft tissues. So this is more of a tumor here that's affecting the tibia here, with some calcification of the tibia and increased calcification of the soft tissue around it. Always evaluate the borders of the tumors. So is it a nice smooth border here, or is there more of a you see a lot of lines here indicating that this is kind of uneven. Nice smooth tumors typically are lean more towards the benign portion, whereas these irregular portions tend to be more metastatic. You can really confirm these through some sort of testing of the tissue here. So they'll do usually some sort of biopsy or something like that to evaluate the tumors a little more specifically. But you can make sure you're evaluating the borders as well as these tumors. And here you see the periosteal reaction. You see this kind of onion peel portion. This is more of a malignant portion of a malignant tumor property, where the kind of lines up and forms these lines. And that's called a periosteal reaction or a periosteal lifting. So when we start looking at all these fractures and things, the basic goals are: we want to restore the patient back to function, we want to prevent any complications, and we want to put them in a position where the fractures can heal well. And we also want to get these patients up and moving as quick as possible, based on the healing and bone properties that we're going to be messing with here. So the first thing is to get the fracture reduced. So if it's, you can do an open reduction, what's called ORIF, open reduction internal fixation, or sometimes they open it up just to get everything realigned properly. That's a surgical condition. Whereas a closed reduction is they manipulate the bone around without surgical exposure. They'll do some traction. They'll try to realign the bone and then re-x-ray it to make sure it's in good alignment. That's a closed reduction, which you'll see with a lot of different fractures. They can realign these pretty easily if it's not too far displaced, or and it's in a good location for them to put traction on. If they have to fixate it through surgery, they'll usually put some plates, screws. Sometimes these external fixators have to be applied if it's particularly with comminuted fractures. Or they can put plates and screws for hardware in there to reduce the fracture here, as they did with this shoulder here. So they put a plate, drilled in some screws, compression screws, to fixate this fracture here of the humerus. So let's say here's some indications of some pins they can put through toes, fingers, those type of things. They can put, like in this case, they put a rod down the tibia to reinforce this fracture. So these are other types of things here they can do. So we want to look at fracture healing. So here you see as the fractures, you see the fracture lines here. Then you see callus starting to form, more callus development here. Pretty much reabsorption of a lot of the fracture here. So you can kind of see that the fracture is healing well at this point. So really want to look at cortical fracture healing. It usually takes a little time for that to happen. So, but they'll do repeat x-rays periodically with these fractures to determine the stage of healing. So how do we know when it is healed? Clinically, we can look at it that way versus radiologically. The radiological healing means there's a bridging callus formation, and clinical is when they're able to start movement, weight bearing, those type things. So for the upper limb, adults usually 6 to 8 weeks, child 3 to 4 weeks, where a lower limb maybe 12 to 16 weeks, and a child 6 to 8 weeks. Like I say, very variable, depends on the status of the patient and how involved the fracture is. Sometimes we'll see some delayed union or malunion of the fracture, meaning it didn't line up the way it was supposed to, got displaced, or did not fully heal. So in some cases we have non-union of fractures where the fracture just does not heal at all, which usually means they have to go in and do some sort of surgical procedure if possible to fixate that fracture either through a screw or plates or something like that. We always want to be on the aware of osteomyelitis or a bone infection. And then avascular necrosis is always an issue, particularly in the hip and some of these areas around the femoral neck where the blood supply gets interrupted and bone dies away. So I think that'll sum up our fracture portion. So if you have any questions on the fractures, particularly with the alignment, some of the Salter, Harris, you'll see some of those in reports. So be aware of what those are, and we'll finish up here with the next section on MRI.